Dr. Minson is the clinical director and advanced trainer for integrated listening systems and has a private psychiatry practice in Denver, Colorado. Dr. Minson received his medical degree from UCLA School of Medicine and is board certified in psychiatry and neurology. Dr. Minson served as chief of psychiatry for Presbyterian Medical Center and director of behavioral sciences at Mercy Hospital in Denver prior to integrating sound therapy into his psychiatric practice in 1990. At this time, please welcome Dr. Minson.
Good afternoon. I'm wondering how close I have to stand to this microphone. Are you hearing me all right? Yes, thank you. It's a pleasure to be here with you. So you might be wondering, after that wonderful introduction, how a board-certified psychiatrist gets into this work. Before I go into that personal story, I will be giving this brief introduction, and I will also be giving a talk on the neurological foundations of the work that we're doing, also as how it relates, in my opinion, to the improvements we see with children who have autism, ADHD, and other disorders, but we're focusing here on the autism population. And finally, I will conclude with some research that has just recently been completed. So you have this shameless display of all of my background and credentials, but I'd like to actually talk just briefly about how I got into this work with using sound therapy. You might imagine it's not something that came directly through my medical practice, but rather a personal experience. Many years ago, over 39 years ago now, we adopted a child at 3 weeks of age who turned out to have a severe learning disability. This was discovered when she went to school. She was very excited about going to school, as had her older 2 siblings. She was adopted. And when school started, she began to have some acting out behaviors that an astute clinician diagnosed as having dyslexia. Not something that sounds very life-threatening or of great concern. We took her to speech and language pathologists, we took her to special education teachers, and tutoring. However, as in not infrequently, many of these children with dyslexia, which is a reading problem, she was never able to learn to do her decoding of the sound-symbol relationships to the point where by the 3rd grade she had diagnosed herself as being both dumb and stupid. This breaks a parent's heart. As time progressed and she got into junior high school and high school, she was further and further behind in her academics. And in junior high, she began to have symptoms of both depression and anxiety. So as a psychiatrist, I took her to my colleagues and she was started on antidepressant medication, later on stimulants. And this story goes on and on through high school where no intervention of a conventional nature was able to help this little girl, my daughter. By the time she's 19 years old, she had hit her 2nd very serious suicidal, life-threatening depression. I suspect you can imagine the fear and the anxiety of a parent, particularly one who has a good training in psychiatry. As a physician, I have access to all of the tools and all the interventions that are available, and we've done all of them, and nothing is working. So the fear and the hopelessness that came about shortly thereafter was quite consuming, but also was an impetus to look outside the box. A friend of mine had heard about a therapy out of France called the Tomatis method, using sound therapy. Well, to my medical ears, it certainly sounded rather strange that we're going to help this little girl to read by putting music in their ears, but the father said, we have to do this. We did this program in 1989 and 90, and the changes were phenomenal. The changes that happened were not just that this little girl was now able to read, but rather that depression that had been resistant to any form of intervention, including medications and psychotherapies, lifted, much like the sun dissipating the clouds on a cloudy day. She was bright, verbal, energetic. Her severe sleep disturbance that had been going on for a number of years also improved. We went to dinner, and we had to go out of town for this therapy, and the waitress brought the check, and she was able to add it up upside down. So it wasn't the improvement per se at that time with her dyslexia and learning difficulty that compelled me to go into this work, but rather the depression that lifted without medication, with no side effects, and it was non-invasive. So I went to Europe and studied for 6 weeks with Dr. Tomatis and also visited many other centers and decided this was going to be a career change for me. A career change because we had something that could help with symptoms of depression, anxiety, learning disabilities, and ADD. I had a clinic for 20-some years that whereby we treated many, many children. 20 years ago, as you know, the incidence of autism was quite small, and it's grown exponentially over the years ever since. Fortunately, in 2007, we developed a system that is portable, that can be used at home. This was always my dream because the clinic system was large, it was expensive, and the therapy had to be done in a clinic. Now we have a system that can be used at home, in schools, in hospitals, and we have trained over 3,000 people who are now using the system because it's so functionally available and useful and effective all across the country. So now I'm going to show a video. We had a problem with getting it to work, so I need to minimize this. Minimize that now, and we should be there.
Here, push play.
We're going to push play, and it should work. This is a video of an ABA therapist using the ILS system in her therapy with a child.
I start my sessions out with putting the music on. I acclimate them to the playroom, which is what I used to do. However, then I go straight into the exercises. There's a short set of exercises that we do that allows, depending on the processing issues we're working with, visual processing, right brain, left brain, coordination issues. And so we do the set of exercises, depending on the child, 15, 20 minutes tops. It actually allows them to settle. It's part of our transition, which I found has been so important to have a physical means of the transition. It gets out some of that energy that they had coming in, gets it out. In the OT field, they talk about that sensory diet. So we do that. We build rapport while we're doing it, and we get their body and mind ready. And so that's about 15 minutes into my session, and then I start right into my rotation of 10 minutes ABA, 5-minute break, 10-minute ABA, 5-minute break, and they are able to sustain that rotation throughout the rest of the hour. And the exercises I thought that was going to be the biggest struggle. But what I found is you can have fun with them, they can enjoy them, but the progress that they then find. Today you heard my older child say, wow, this is so much easier. I mean, this is a child that couldn't do sports. He couldn't move and coordinate his body a year ago to be effective. He tripped, he fumbled, he was very klutzy, and he could have never caught a ball, bounced and caught a ball, right hand, left hand, none of those things. And he felt successful today. When you heard him say that, I didn't prompt it. That was him, and that was because of the ILS. And that works then across my goals as a therapist, is to increase his self-esteem, increase his social skills. Now he can go out and play with kids. He can ride his bike now. He can be active. I immediately started seeing their anxiety reduced. They were more attentive to me. They were calmer. They were just overall more available to me, so that when I was doing the behavioral therapy, we were making progress. They were then able to sit and do that. They weren't throwing the fits the whole time. They were taking the deep breath, even if they were tired, even if they didn't necessarily want to do what we were doing. They could get through it now. I would give them the break, and then they could do it again. And so my hour of therapy became an hour of therapy versus 15 minutes with a lot of struggle. And so the wonderful thing about it is that it not only allows them to be available to me, at the same time, they are making the connections in their brain. They are changing their brain so that the things that I'm teaching them can stick, that they can retrieve it, that it's just available, and then it lasts when they leave here. That's the other thing. It's so hard working with the autistic population to have them take what they've learned and transfer it to another environment. That is really one of the largest problems that we have. The great thing that was happening is they were transferring it.
I did that, and now I just need to do that. Oops, how do we get that?
Here. Let's bring this back up.
There we are.
There we go.
Okay, I can finish.
Go back. There.
Okay, I must have been so nervous about the video working or not working, I left out some of the story on my little daughter. The conclusion of that was that she was 19 when she received this therapy from Dr. Tomatis' approach, and I did go to Europe and study with him, as I mentioned, and brought this back to the States where we have been introduced that particular form of therapy. And then I've studied the Berard method, the therapeutic listening, and others from the originators of those other systems, just about every system that's available. And we created our own system, as I mentioned, in 2007, which is now portable and transportable. The issue with my daughter was that she was 19, and she not only was able to overcome her depression, but her reading took off, and she was able to get her high school diploma by correspondence. She was living at home, and one of the greatest achievements that came about from that therapy was she moved out of the house. And you can imagine how important that was, that she was able to be independent, be on her own, and take care of herself. And rather than keeping a job for 3 to 4 weeks and being fired because she wouldn't show up or her bad attitude or one thing or another, she was able to get a job on her own. We lived in Prescott. She got a job in Phoenix and kept it for a year and a half. And she made several other advances in professions, including winding up in the banking industry, where this little girl could not remember 4 times 4 the next day. And she was having, wonderful experiences with finances. And we just happened to ask her one day, "Sweetheart, how much money are you handling in this bank?" And she said, "Well, anywhere from $150 to $180 million a day." And she was involved in high-end real estate in the Phoenix area. So it was a very successful story, and it was this kind of thing that probably would take for me to change careers in the way that we did. So you saw a video by a doctor who does the ABA therapy, and she uses this system in her clinic with wonderful results. So what I'd like to do is talk to you a little bit about what is the ILS system, show you some pictures of that, and then I would like to go into at least my idea, not all of which is proven, with regard to how is this helping the brain to change in ways that help to improve the lives of children with autism. So what is it? First of all, it is a multi-sensory, a simultaneous multi-sensory input to the brain that includes these various sensory systems that you see listed here. And as the child progresses and can do more difficult things while they're on a balance board and maybe doing a visual tracking exercise, we might have them do counting backwards or math in their head, which is where we have the cognitive processing, or maybe asking them questions like, name as many fruits as you can that are the color red. So they're using cognitive processing at the same time that they're doing this intervention. Some key points I'd like to emphasize that underscores my approach to this work. One of the underlying premises that I've had for quite a while is that the higher cortical function of the brain is dependent upon the speed, quality, and the integrity of these subcortical processes. When my daughter was getting her speech language help and her reading tutoring help, all of it was cognitive. She would hear a word, have to pronounce it, see a word, have to put the sound association to it. And many therapies that I saw subsequently for children who came to our clinic that were receiving help for a number of disorders, it was all higher cortical, and it often was taking a very long time to achieve results. And when the results were achieved, they often didn't hold as well as one would hope. That was certainly true in my daughter's case. So when I started using the Tomatis system and then our own system subsequently, after about 3 years, we changed to our own work, We have a bone conductor, which I'll be showing you on the slides here, that stimulates the vestibular system. And it became clear to me that the changes, rapid changes that we were seeing, were due to the fact that we were improving subcortical processing and thereby improving cortical processing. The cortex was freed up to do what it was designed to do, rather than do all the management of the subcortical processes. Further evidence, when I began training OTs, we started training therapists back in the year 2000. And many of the therapists who came to this initially were occupational therapists who were already using a variety of movement activities as a part of their clinical skills. And they found that using the listening system with their movement activities accelerated the gains at which their OT therapy skills were sticking and how fast than they did last. Much, much faster. So this was further evidence that using a multi-sensory approach rather than just auditory and vestibular was going to give a further advantage in terms of brain changing and brain function. So the system we have now includes a lot of movement and other activities, as you saw on the first slide. And finally, the neuroscience, and these are all articles that you can look into, does show that the more simultaneous information the brain receives, the better its organization, processing, and function. So these are the three components of the ILS method: the auditory, which has air and bone conduction, a lot of movement with visual, balance, and coordination exercises, and also an interactive language program. And we all know how language is a challenge for children with autism, and once they have other subcortical processing improvements and auditory improvements, we have a system that really addresses the language system very directly. This is a picture of the system with this iPod that is loaded with specially treated music that has a lot of psychoacoustic treatment to it that we won't go into now. And it has lossless compression, so all the frequencies are present in the music that's loaded. It has an amplifier that you can see where the iPod is piggybacked onto it, headphones that are equipped with a bone conduction, and a little pack that you can wear around your waist to be highly mobile. In addition, I just wanted to insert this particular slide on a new product that has come out recently called the ILS pillow. And there are some of these at the booth, as well as a flat pillow. And the reason for mentioning it is because we designed this initially with the idea that a lot of the kids who are being seen in OT clinics and others have tactile sensitivities and aversion to wearing the headsets. So we wanted to find a means by which we could maybe accommodate their tolerance of the headsets. This pillow has some bone conductors embedded inside of the pillow, and a little player that has the music. They just lay their head on there. It's ergonomic. One side is larger than the other, so you can see it works for both adults and children. Well, the results that we were getting was sleep improvement. Initially, as I said, we thought this would help desensitize the child to the headphones. That worked. But also, many of them had sleep disturbances. The parents had sleep disturbances, so they started using it. So we now have 2 studies ongoing with the pillow. One is being done on children with autism and insomnia, another with children with ADHD and insomnia, and these studies are going on currently. So it's been very, very successful in looking at, so far we're needing to do more research, but anecdotally we're getting lots of feedback that this improves sleep onset, sleep quality, and sleep duration. The music that we use is classical music, mostly Mozart's music, and there are others chosen for their frequency content, their rhythmic content. You can imagine a waltz, we would use that frequently when you want to help a child have a sense of rhythm because of the 1, 2, 3, 1, 2, 3, that's very strongly present in waltz. The music is processed by a number of methods, and time doesn't allow us to go into that, but it's not the same as just putting a CD and wearing headphones on your head. It's not to be confused with other systems that are out there. People hear the word listening, they hear the word auditory, and they think this is the Tomatis method, which it is not. And also, it's not music therapy. I think music therapy is wonderful. That's usually done, however, with sound in an open room with a lot of activities for rehabilitation in hospitals and clinics. Let's move into some of the ideas that I have around way this system is working. Dr. Merritt talked about the child's brain is making new connections. And I realized that she stated that anecdotally in terms of the fact that the child was now processing and doing activities that he couldn't do previously. And she's actually right. We know about neuroplasticity. We know about the brain's ability to change form and function in response to stimulation. And even that stimulation can be thoughts, ideas, memories, creative thinking. These also improve and make new interneural connections. Again, when you stimulate a nerve and you repeatedly stimulate that nerve, something else that occurs is something that calls long-term potentiation. This simply means that you strengthen that connection. So the next time it receives a stimulus or an impulse from the auditory or sensory motor system, it takes less of a stimulus to activate that system, that pathway. So this is very, very important. Then when you combine an auditory with a vestibular and with a visual stimulus simultaneously, we know that those are different areas of the brain. But when you do that simultaneously, Hebb's law says that neurons that fire together wire together. So by that process, we're increasing interneural connectivity between different brain areas, encouraging their simultaneous functioning and functioning together harmoniously and synchronously. And this is what we see in fact. I thought that it would be interesting to talk a little bit about the genetics and other parts of the research that's coming out. So she said they're making connections. And you've heard me say already, I believe that the underlying feature for a lot of disorders that we see in children as well as adults have to do with poor, disorganized subcortical processing. We've talked about neuroplasticity that says we can improve those connections. So one of the questions I have is part of the autistic disorder due to a lack of connectivity or problems with connectivity. I don't want to suggest this is the be-all and end-all, but I think it's a piece of the puzzle. And there was a study done, this one is by the Science of Translational Medicine that was published in 2010, that showed that by looking at the white matter, they can now look at white matter as opposed to just gray matter by a particular type of brain imaging called diffuse tensor imaging. And they found that the frontal lobe was over-connected to itself. What does that mean? It means these pathways are hardwired and there's a lack of flexibility in terms of moving the energy information to other parts of the brain. How do we see that in children with autism? They have difficulty changing things. They get stuck in a routine. Maybe it has something to do with this hyperconnectivity. And there was also diminished communication between the front and posterior parts of the brain. Other research has pointed out to the fact that they're discovering that autism is considered in part a disorder of aberrant neural connection. And then a fascinating study, the third one on the list here, from the American Journal of Psychiatry, followed children who had a particular gene that was known to be associated with the onset of autism. And these were children who were siblings of children who had autism, and they had that gene. And they watched these children over time, and these children the children that did have and ultimately develop autism did have an increased hyperconnectivity and disorder of the white matter. So there's something there for us to think about, and I believe that's one of the ways that ILS is helping the brain to function more efficiently is by breaking up that hyperconnectivity or hypercoherence as it's talked about on brain maps. Dr. Merritt mentioned that this youngster was calmer and less anxious. In my 20 years of practice using the sound therapy, by far the most common report from parents who brought their children in was, my child is less anxious, my child is calmer, and my child is happier. Now, they didn't bring their child in because they were anxious and not calm and not happy. They brought them in because they had ADHD or autism or a learning disability or a sensory processing disorder. But one of the first changes that occurred was in that the children were in fact calmer and less anxious. One of the nerves, of the cranial nerves, that has to do with the autonomic nervous system, you've heard of the sympathetic, the fight-flight part of our nervous system, and you've heard of the other side, which is the rest-digest. That nerve, 75% of that output is carried by the vagus nerve. Well, that doesn't sound too terrific until you realize that the vagus nerve sends an auditory branch to the external auditory canal and is stimulated by sound. These children also improve digestive function, bowel control, bladder control, because they now have more awareness through the stimulation of this nerve and the awakening of those interoceptors, so they have more body awareness internally. And it downregulates the fear response through the amygdala. I think it's the vagus nerve that figures very prominently in that. If you'd like to know a lot more, maybe more than you really want to know, about the vagus nerve, there's a wonderful book by Steve Porges called The Polyvagal Theory, and everything in that book is about the vagus nerve, including one piece of information which is very relevant to our issue here, which is the anterior vagus nerve is involved in social engagement. And in the research that I'm going to show, one of the main changes that we saw in this research study was improvement in social skills, social engagement, and relatedness and connection to others. So it may very well be that this vagus nerve is even more important than we realize, not just bringing about calming, but also helping with social engagement. This is the location of the vagus nerve. I don't have a pointer that I can point to up there, but I'm going to show you right here is where the vagus nerve actually attaches or sends a little branch to the auditory canal and the anterior portion of the tympanic membrane, and it is stimulated by sound. She said, these children are now more available to me for learning. Rather than spending 45 minutes of my hour with them, getting them to relax and attend, I now am able to use the whole hour for doing my therapy. And all of these sensory systems go into a portion of the brain, in the midbrain, called the reticular activating system. And this system is involved in calming, but also in arousal. Have enough awareness, attention, to be able to focus and attend on whatever it is that they're doing. The cerebellum. I mentioned one time that I'm having a love affair with the cerebellum, and it's true because this wonderful organ that has been ignored for so long that we thought only regulated the motor systems is actually involved in language, emotional regulation, cognition, memory, as well as motor. So when a child is on the balance board and they're getting stimulation from the vestibular system, the cerebellum, as well as other structures, are being strongly stimulated, and I think plays a strong role in the improvements that we see in overall brain function. The bone conduction that sits on the top of the headset that we showed earlier has a gentle vibration through the skull, which is carried into the vestibular apparatus that then connects with the vestibular system. Thereby we see changes in muscle tone, much more muscle tone, coordination, balance, eye-hand coordination, orientation to sound, reflexes are all improved. The somatosensory system gets into where I talked about a moment ago, the importance of movement, so that we have children doing some kind of movement activity while they're doing their listening. Generally, listening is done 3 times a week for an hour, and we like for them to do some of the activities of movement for at least 20 minutes out of that hour. And they can do that much longer if they wish to. So once the somatosensory system and subcortical systems are integrated, the cortex is freed up. It doesn't have to use its resources to maintain balance, to think about coordination, to plan sequences. They become automatized through the cerebellum and other neural structures. So in a sense, in summary of this part, we're training the brain to do the kinds of things that we want it to do in everyday life. Riding a bicycle requires balance, motor planning, and visual processing, among other skills. Reading, you have to have an auditory as well as a visual processing going on simultaneously, and you have to make the sound-symbol relationship. So these are all different systems that we're addressing simultaneously, and we do see improvements in those areas. Children often have a hard time having a dinner conversation. They can't focus. They're distractible. They have a lack of inhibition of impulses. So these are social issues that interfere with the kind of relatedness we'd like them to have. And so by getting their attention calmer, ability to listen and have control over those impulses and improving language, they're going to be able to participate in these activities at home and in school. She also said in her video that she says that it transfers. It lasts on the one hand, that's Hebb's law, and it transfers, it generalizes to other skills. This has a lot to do with the mental flexibility, the memory of the skills that you've learned, being able to pull back that memory, and then through the frontal lobes and the executive functions, use that in a new way. So you transfer it to new skills, including planning, reasoning, execution, and memory. It also improves the dialogue between the two hemispheres through the corpus callosum. As you know, there's a great deal of talk between the two hemispheres where they're sharing information all the time. There is not time to go into this currently. It's just worth noting, you may want to look into this more, that a lot of the research is also pointing out that the corpus callosum, the role, is not only to carry information from one hemisphere to another, but to inhibit activity from one hemisphere to another that might be interfering with the primary hemisphere whose role it is to be in charge at that moment. So there's both excitatory and inhibitory functions that are carried via the corpus callosum. The language program, as you can see here, this young boy has the headset on, has a bone conductor on it, there's a microphone, and there is an iPod loaded with dozens and dozens of language skills. It might start out with a child just humming. If they can sing, they will sing. Some of the clinics, they're using our system and they're working with children with autism. They will actually tape the microphone to the swing or to an activity, and the child, in making spontaneous noises, begins to associate that sound with their own activity. They're producing it. And we use this as a gradual way of getting them to become more in tune with their voice, with the fact that they have control over it, and through that we get them to hum on demand in different tones. We want to work on inflection, prosody, these kinds of things, and depending on their developmental age, levels, and skills, we move into repeating words and phrases, maybe single words, maybe multiple words. There are exercises for training the ability to listen in background noise, something called auditory figure ground. These children have a lot of trouble in classrooms, cafeterias, when any other noise distracts them, so there are exercises on that to strengthen that ability. Many other things like dichotic listening, being able to hear through both ears and to integrate that information. Frequently, someone speaking on one side an ear will interfere with the integration of what's coming through the other side. So the language and communication, the interactive language kit, helps with our expressive language, also nonverbal communication. Prosody or intonation, we know that children with autism often have a flat, unmodulated voice. And so by this immediate feedback, you really have to experience it to feel it, that when you have the bone conduction here and you're speaking, you get a kinesthetic understanding and feeling of your voice and your articulators and the tonation of your voice, which gives you more self-control and ability to self-regulate your vocal expressions. I mention eye contact because in my practice it was not uncommon for a child to come in and the parent to say, "Look at the doctor when he's talking to you." And this was a little bit offensive because, in my opinion, the child was doing his best to listen. And some children are so visually aware that any kind of visual processing that's going on, they will interfere with their auditory processing, particularly if they have weak auditory processing skills to begin with. So by looking down, a child is often trying to listen. So let's be aware of other things that might be going on and give them credit for doing the best they can. They're not trying to be evasive by any means. Seems like this is frozen for a moment. Oh, I see what's happened. I put something up here. Let's click that off. Here we go. I'm going to put myself on a limb here for a moment, because another aspect of working with many, many children, not just children with autism, that presented themselves to me in my clinical practice was that children were not only frequently calmer, less anxious, happier, they had deeper feelings of empathy, compassion. The experience to feel what someone else is feeling was beginning to emerge. Now, I don't think that our system puts that in there. I think it's allowing them to make connections with that part of the brain that controls empathy, relatedness, and connections. But by all means, they just are more, they're more I love you, mommy. They are getting the meaning of jokes and subtle meanings that they were unable to get before. Humor, abstract thinking, these are challenges for children with autism. So there's a whole sense of communication at an empathic, compassionate feeling level that I begin to see in many, many children who have been through this process. And I mentioned earlier the polyvagal theory by Stephen Porges that also relates to this whole idea of the vagus nerve being involved in social engagement. Going out on a limb means that I am wondering if the right brain doesn't have a lot to do with this improvement. A lot of research, and some of that by Dr. Melillo and his centers, talks about autism as being a deficit of right brain activity. And a lot of the music that we begin the process with, along with movement and vestibular input, is preferentially activating the right hemisphere. So this may be the rationale for how and why we're seeing these improvements. I'm now going to go on to a study that was done by Teresa May Benson, an occupational therapist in the Boston area, who established a foundation whose express purpose is to do research. And this particular study that I'm going to present is a single study design where subjects are compared to themselves. It's an ABA. We won't confuse that with the ABA therapy, but rather a design which went for 8 weeks of a baseline data accumulation. Then there were 12 weeks for the intervention, and then another 7 weeks for the second baseline. During the baseline, the parents were contacted on a weekly basis for 10 minutes or so with a questionnaire, so that when the intervention started, and now you're beginning to gather data and how things are going and what are you noticing, the baseline already established this pattern so that you cannot say that this is a Westinghouse effect. Well, now during the intervention, you're paying more attention to them, and because of that, they're getting better. The same attention was paid to them for 8 weeks prior to starting the intervention. Then the intervention was initiated, which was listening at home under supervision by the parents, or guidance by the parents and supervision by the therapist. And they listened for 1 hour, 5 times a week. We only had one problem with that. One overzealous mother felt that, well, if this is good, maybe more is better. And she had her child doing it 7 times a week. And he began to be irritable and cranky and have some crying spells and wasn't sleeping as well because he was overstimulated. So you don't want to take something like this and just do more, because it is a form of stimulation to the brain by all means. The study was done in 4 clinics across the country. These are clinicians who have been trained by ILS and have worked with autism and children with autism. So there are 4 clinics, therefore this eliminates a bias that might have been produced had we had only 1 clinic where they were skilled, particularly at working with this system and with children with autism. So this also eliminates another bias, because all 4 centers were getting similar results, but they were totally different clinics. There were a number of study measures, as you might imagine, and by the way, this has been completed, and Dr. Benson is now writing it up as we speak for publication. I don't know where she's going to be submitting this at this point, but she has at least 3, if not 4, papers that will be coming out of this study, and they will be published. So the therapist objective measures were from the auditory processing measure, was a scan, C, and the TAPS. TAPS is a test of auditory perception skills, and the scan is a standardized, validated test using a CD to measure auditory figure ground, filtered words, competing words, which is a dichotic test, and competing sentences. There were subjective measures also by the therapist, which was the M-FUN. The M stands for Miller, FUN for function. These activities on the M-FUN are functional activities. It's not just how long can you stand on one foot. Can you string beads? They have to do, an example would be carrying a lot of items on a tray, which recapitulates what the child does in the cafeteria when they have to get their tray and to carry the food to the table and sit down. So all of the activities on the M-FUN tests have been validated and standardized using functional tests that relate to real-world activities. There's participation scales checklist in that, and also global impression scales that the therapist was using. There were a number of parent measures, and parents are, to me, very astute observers of their children's behavior. There's the adaptive assessment, the ABAS, which most of you are already familiar with, the M-FUN participation scales. A sensory processing measure is a very important one, which is often used when there's an absence of other measures, such as the ADOT. If that's not available, this is a specific test that looks at autistic behavior specifically. And then there's the social responsivity scale and others that you can see here. In addition, they were asked to keep a daily log in their weekly booklet. The results from this study, involving 18 children from 4 different centers, were that both parent and therapist measures demonstrated highly significant, statistically significant improvements from their pre and post measurement tests with a large effect. These changes occurred in the level or the areas of social skills, emotional regulation, which is extremely important, auditory processing and communication, visual, fine, and gross motor skills, and behavioral regulation, with decreases in atypical behaviors. I should briefly mention that the M-FUN is a test also of visual, fine motor, and gross motor activities. The gains as a result of this program were sustained after the treatment period. I'm not a statistician, so I did spend quite a bit of time talking to Dr. Benson so I could interpret this for you, and that is that the effect size ranged from 0.28 to 1.45, which meant nothing to me. So what she said, effect size is a measure of the observability and the observability of these changes. Excuse me for hitting that. So at the bottom, we explain effect size. It reflects the magnitude of change and how easy it is to observe the changes that you're measuring. And they're measured in this Cohen's D effect. So help us interpret the slide. Anything greater than 0.35 are considered moderate, so at least it's a positive change. Effects greater than 0.5 are considered moderate to large, and effect sizes greater than 0.8 are large. So that's the way you can interpret the numbers. So here's the results on social skills. Now, remember, social skills are one of the issues that most therapies are having some difficulty making major changes in, especially early. And these children began to see major changes in their social skills rather early on. So there were specific things they looked at. Social awareness was a large effect. Social cognition, even a greater effect. And social communication was a very large effect, as well was a decrease in autistic mannerisms, and the total score had a very significantly Cohen's effect. So this illustrates functional gains. Here's an example of one of the 18 children that we pulled out for a case study example. This youngster was 6 years old. He was treated at the Seattle Children's Autism Center, was diagnosed with high-functioning autism by the ADOS Module 2, and also had an anxiety disorder and a phonologic disorder. Whether those were discrete disorders, I don't really know. I haven't seen many autistic children with autism who don't have anxiety and don't have some kind of phonologic processing disorder as well. Nevertheless, these are the scores pre and post from this young man's tests. And all of the scores on the right went up, and this is a good sign based on these particular tests. The Scan 3, which is auditory processing, as well as the test of auditory perceptual skills, the fine motor, visual motor, and gross motor skills also increased significantly. And also there were major changes of improvement by clinical observation. I should mention, because I questioned the researcher on this, Dr. Minson, about these observations. Many people, and myself included at times, have said, well, if there's just observations, how can we really hang our hat on them? And she said these are standardized observational checklists. Many of you might be familiar with a Conners, for example. That's a standardized questionnaire that's used in research, a Beck Depression Inventory Scale, and so forth. So these are standardized questionnaires that have a high degree of reliability between raters. Then the parent subjective measures are, again, these were questionnaires that have that same standardization. And you'll see that the sensory responsivity scale, this child went from 87, which was a severe, to mild to moderate. Social skills, below average, quite below average, to below average. And I'll let you read through these without my having to repeat what's already in front of you. The ABAS, I will mention there are a few children whose scores didn't change statistically on the percentile ranking as much as one would expect, because several of them had birthdays during the study. So by having a birthday, they went from the upper end of a particular age level to the lower end of the next age level. But their raw scores did go up. That's just by way of explaining how some of the changes in that particular test weren't as robust as some of the others. The weekly booklet talked about emotional regulation, and then going down is obviously better here. They were having fewer emotions. Their social skills were improving, so there were less problems. Auditory listening skills were improving, so the lower numbers on the right-hand side here are actually improvements. Here's some of the notes that came from the mothers keeping records on a weekly basis. She talked about her son now trying new foods and participating in family meals. This is after only 1 week of using the ILS system 5 days a week. By week 3, he was calmer in the car. And again, you can read the changes that occurred by weeks. These are 2-week intervals that she just pulled out. Even went sledding, and so his fear level had been coming down. He was more adventurous, more risk-taking. And he then also began to initiate play. This is wonderful to hear when kids will initiate play from a social perspective with another child on the playground. And he continued to play with this child undirected for over 30 minutes. He was playing with his brother more often. Most of us know that usually siblings are getting into it one way or another, and so there's more participation with the brother. He was calm and relaxed, more self-care, dressing, brushing his teeth, the kinds of things that are going to help him to be self-sufficient and independent. Week 12 was a perfect week. He even was able to have a sleepover with a friend. And the improvements in handwriting were also beginning to emerge. On this behavior rating scale, I need to move my glasses here, the blue line is where she is asked to rate your child's overall behavior. So the more negative behaviors there are, the lower the line. That means that that's not so good. And how much of a problem were these behaviors, the green line? Well, they were a big problem. The hitting, the biting, the kicking, so forth, those were big problems. During the intervention, the frequency of behaviors diminished, it dropped. And the degree to which they were troublesome and bothersome also was improving dramatically. The slope of the line is going up, so that's showing a continuous effect during the intervention. Then the intervention is stopped, and we collect more baseline data, and you'll notice there's a drop. Well, this is a good thing because it says the therapy was doing something. And when you withdraw it, it's still much, much better than it was in the beginning. And also the line flattens out. It stopped ascending. If the line had kept going up, we'd have to say, well, something else is accounting for these changes. It wouldn't be the intervention that we were utilizing. So this is a very powerful demonstration of this child's changes. Under skills rating, you can see here that the blue line, if you can see that, rate your child's auditory processing skills, and green, your social skills, and rate your child's emotional regulation. And these were in a negative category in the first baseline. They improved during intervention, and then you see the welcomed drop afterwards, but not to pre-existing levels, and a flattening out. So this clearly shows that the intervention was the thing, the intervention was what made the difference, and not some outside influence such as learning how to do yoga or playing judo, doing judo or something else was not the reason for the improvements. So that completes the demonstration or the presentation of the research project. Just very briefly, I'm going to comment on another study that she was doing, which was a survey. She was interested in finding out for therapists in the field who've been using the ILS for a number of years, what is their degree of satisfaction and what are they seeing specifically in terms of change? And these are therapists who were seeing children with autism. And the survey, the power of it actually comes from the number. I think it actually involved therapists, about 80 therapists. We had a good return on the survey, about a 10% return, which is good for questionnaires that are sent through the mail. And they were 80 therapists involved here. And these therapists had a great deal of training. Many of them had been in the field more than 10 years, so these weren't inexperienced people. I'll just go through the points here. What they're looking at is many, many areas. There were 24 specific outcomes in 3 different functional areas, and they used a 5-point scale to measure the changes that they were experiencing. 1,304 children who have autistic spectrum disorder diagnoses by these 80 different clinicians. So the respondents who returned this information were mostly occupational therapists, but a number of speech pathologists, psychologists, as well as educators. 69% of them were respondents who had over 10 years in their profession. 60% of the time, the therapists combined ILS clinic programs with home use, which means they've been trained to use the professional system in the clinic, but also had the home system that I've been describing to supervise at home. And the program frequency for these clinics reporting varied from 3 to 5 times per week for a total program length of 40 to 60 hours. So the significant areas of change reported by this 80-plus therapists were that self-regulation, 87% of the children had responded positively, either in a usually or always frequency. That's remarkable. Attention improved in 87%. Ability to make transitions. Remember that brain flexibility that I was talking about? They're no longer stuck. They have more choices within the neural transmission. And the ability to follow processing and verbal instructions improved tremendously. Sensory integration processing and motor coordination. And they were asked, would you recommend this to another clinician based on your experience? And 83% of them said they would definitely recommend this to their colleagues, and 14% were somewhat likely. And I'm not sure why they're somewhat likely. Maybe they didn't want the competition in their area. That's one possibility. But nevertheless, there were very, very positive signs here. That's my presentation at this point, and there's more information that is available to you on these websites, and we also have a booth outside that if you'd like to see or hear what that bone conduction hears and feels like, or learn more about it, please stop at the booth, and I thank you very, very much for your attention.